So let's start off by looking at the current KPIs for ovarian stimulation. What is out there that is published? So recently we have the Maribor consensus, which is a consensus for clinical KPIs in assisted reproduction. And what are the KPIs that are focused on ovarian stimulation? And as you can see here on this slide, the ones that they have highlighted as indicators, performance indicators, are cycle cancellation rate prior to oocyte retrievals. That is, before you go for oocyte retrieval, what is the cycle cancellation rate, and the OHSS rate. And they've given what should be the competence and benchmark values based on the ovarian response groups. That is your poor responder, normal responder, and high responder. I'm not going to go through all the figures because this paper is available and we can all reference it. So this is the Maribor consensus, which is giving us clinical KPIs, and this is what it is for ovarian stimulation. They've also stated a little bit more further. They've stated rate of number of oocytes retrieved, occurrence of empty follicle syndrome, oocyte retrieval rate, and proportion of M2 oocytes retrieved if we are doing ICSI. However, they have not given any specific definitions for any of these, and what they said is that to refer to the Vienna consensus, that is the embryology lab KPIs that has been published. And based on that, the two definitions are for the proportion of oocytes retrieved, it is the number of oocytes retrieved by the number of follicles on day of trigger times 100, and the benchmark value is 80 to 95%. And the proportion of M2 oocytes retrieved is mature oocytes divided by number of oocytes retrieved as a percentage, and the benchmark is 75 to 90%. So this is what is currently available in terms of KPIs, clinical KPIs. So this is what is out there that is published. The other thing is that when they given us how to calculate a particular KPI, for example, proportion of oocytes retrieved, they have not told us what should be the size of the follicles on the day of trigger that we should consider as the denominator. We have core outcomes, the commit, of which was published recently for trials or research in clinical research in reproductive medicine and fertility. And here it is the two documents published simultaneously in human reproduction and fertility sterility, and the table shows what the outcomes, the core outcomes that were suggested. However, if you look at it, given that if you were to do an IVF treatment cycle, a significant portion of the IVF treatment involves ovarian stimulation, there is no outcome for ovarian stimulation in this core outcome set. So then we have to question, is this fit for purpose for all types of clinical studies and IVF studies, where, as we know, ovarian stimulation is a very critical and significant part of the treatment cycle. And also, if we were to apply the currently existing KPIs, clinical KPIs, in relation to ovarian stimulation, which are so sparse, as you saw in the previous two slides, with definitions not clearly stated on how to define the denominator, then we will be overlooking the suboptimal response group. And we've heard over the lectures this morning about suboptimal response or hypo response, and we all know that we are faced with this from time to time. It is a daily occurrence in our clinical practices. And thanks to the Poseidon group, now Poseidon has become bread and butter for all of us in our clinical practices and to plan our strategies and clinical management. The Group 1 and 2 do recognize the suboptimal response or the hyper-responder group. However, in the Poseidon criteria, many of you who are actively engaging in Poseidon criteria have said that the definition of suboptimal response is more of a retrospective definition, that is after you finished the ovarian stimulation. So hang on, dear colleagues. We have taken your messages on board and we are going to refine this slightly, and I'll leave it to the end as a suspense. You could perhaps ask at the panel discussion how we could make this more prospective and dynamic to introduce it into every cycle as you go on, not just retrospectively. And we also know now, with regards to the suboptimal or the low prognosis group, that this is a significant proportion. So if we are missing the Poseidon 1 and 2 with our current KPIs, of which there are very few, then we are missing our Poseidon group 1 and 2 patients. And we know from studies, and thanks to Sandro Esteves, who has been publishing on this subject on a regular basis, group 1 and 2, just see what the proportion of patients in our day-to-day practices are with regards to group 1 and 2. So we will be missing these patients, and therefore we are not able to fine-tune treatment or personalized treatment for these patients if there are no KPIs to capture these patients within the treatment cycle or even at the end of the treatment cycle. So current KPIs for ovarian stimulation, as we can see very evidently, do not reflect the full individual ovarian potential and sensitivity to ovarian stimulation. They cannot identify the hypo-response or the suboptimal response group, despite them being a significant proportion of our patients. And there is lack of comprehensive key performance indicators for ovarian stimulation, despite ovarian stimulation being a crucial aspect of IVF treatment. We are very good at criticizing or arguing with our laboratory or embryology lab colleagues that the KPIs have fallen short of this or that when we analyze our patients. But do we analyze our clinical practices, or especially with ovarian stimulation, with such intensity, and are we able to do better? Not really, from what we have and what we are doing. So what is an ideal ovarian stimulation? Because we want to have KPIs to bring about an ideal ovarian stimulation to give the best outcomes. An ideal ovarian stimulation is one that maximizes the pregnancy potential of each ART or IVF cycle. So individual cycle has the best potential and the best outcome. And this is by having the optimal number of oocytes with optimal quality. So we've heard over the last few lectures about oocyte numbers and oocyte qualities, and they can and should go hand in hand. The other thing which I want you to just notice or focus is that we are not stating maximal, we're saying optimal. Optimal is a good number of oocytes, not necessarily excessive number of oocytes, and definitely not low number of oocytes if the woman has a good potential. So a stimulation which will give you an optimal number of oocytes with optimal quality to increase the live birth rate in a fresh cycle, if that is possible, increase cumulative live birth rate, decrease the time to pregnancy, and no OHSS. That should be the aim or the ideal stimulation. And we know, we've seen time and time and again, and stacks of papers that have reproduced the same thing from different parts of the world, which gives us confidence on the finding that the number of oocytes is a very strong prognostic indicator of IVF success. So if you have a good number of oocytes across all age groups, the chances of live birth are higher, and this applies across all age groups. And the same with regards to cumulative live birth rate. So if you want to maximize the efficiency of a cycle, then you want to get a stimulation that you have a good number of oocytes, that you increase the cumulative live birth rate. And again, that is reproduced everywhere, showing that oocyte number is one of the most important prognostic variables along with female age. And then again, you have this very interesting study, which Christos has shown in in his lecture, which shows that if you have more number of oocytes, then the chances of having there is a higher chances of having more euploid embryos. More number means optimal number, not necessarily excessive, because we're balancing safety and efficacy. And if you have more euploid embryos, then you have a shorter time to pregnancy. And shorter time to pregnancy is more cost effective, less burdensome for the patients. And also the concept of one and done, whereby you want to give a ovarian stimulation for a couple or an individual, whereby you want to complete them to complete a family of 1 and 1 children, that is 2 or more children, not twin pregnancy. And here you see the top line is that there is again a positive association with more number of oocytes or optimal number of oocytes with the chance of completing a family from 1 stimulation cycle. However, this is not possible for everybody. This is only women with good ovarian reserve and young women that we can achieve it. But knowing that it cannot be achieved in all groups of women, especially women of advanced reproductive age or women with a low ovarian reserve, then we can extend that or use the same concept, that is fewer and finish. So fewer number of IVF cycles to finish or to complete a family. So when you have a patient in front of us and we are discussing, then it is important to understand what their outcomes are, what their desired outcome is, whether it is one child or they wanted to have more than one child from that cycle, and accordingly we plan our treatment cycles. And here is the concept of individualization. This is all routine practice for us. We individualize our ovarian stimulation on a daily basis. And how do we do it currently? We categorize women based on their AFC or AMH into poor, normal, and high responders, and then individualize stimulation to these ovarian response groups to obtain an optimal number of oocytes and the best efficacy clinical outcomes. And most of the guidelines, including the ESHRE guideline, by the way, this guideline has just undergone an update and is out for stakeholder review if anybody is interested. So the ESHRE guidelines, the previous one and the current one, which is going to come out, have broadly categorized women as low responder, which is in other terms a poor responder, normal responder, and high responder, and then have given us recommendations on the treatment strategies for ovarian stimulation or embryo transfer for this group of patients. So it is only these three groups that are usually focused in majority of the guidelines. And here again, the suboptimal response group or the hypo-response group is not in the context of these guidelines and other guidelines. But again, as we know, and as we saw before, these suboptimal groups are a significant proportion of our patients that are not being recognized. So these suboptimal patients, group of patients or hypo-response, have 20 to 30% lower live birth rate compared to the normal responder women. So they're not poor responders, they're not normal responders, they're the in-between group of women. And as you can see in this chart, the red is the live birth rate for the suboptimal response group. And here they will use in a fresh cycle, and it is significantly lower. They also have lower cumulative live birth rate, and they're more likely to benefit from any interventions in increasing or improving the stimulation or fine-tuning the stimulation strategies than poor responders. Poor responders, that is the Poseidon 3 and 4, there's not much we might be able to do for them, but for these suboptimal responders, if we recognize them in time and accordingly individualize or fine-tune or precision stimulation protocols, we will be able to improve their outcomes in terms of live birth rate and cumulative live birth rate, and perhaps fewer and finish as well, or one and done. So again, I'm not going to go into the KPIs. Now I think we are very clear of what these KPIs are. So these KPIs are not in the published Maribor clinical KPIs, but here these are published KPIs that are in addition to them. And what are these? These are the follicle output rate. And again, you have the normal and you have the suboptimal response or the hypo responder. Then you have the FOI. Again, I'm not going to go into the details because the previous speakers have very elegantly alluded to them. Here you have the normal response, that is the normal FOI, case 1 and 2, although one has a higher antral follicle count, the other has a lower antral follicle count, then the oocyte number is as per prediction of as predicted by their antral follicle count. So it is a normal response. Whereas case 3 and 4 are the suboptimal response, the low FOI, or the hypo responder. So they have this good similar antral follicle count as case 1 and 2, but when it comes to the endpoint, that is the oocyte number, then there is lower than the case 1 and 2. Then you have the ovarian sensitivity index, which is the total gonadotrophin dose divided by the number of oocytes retrieved. And here you have two examples. So example 1 requires a higher gonadotrophin dose to get the same number of oocytes as the example 2, which required a lower gonadotrophin dose to get the same number of oocytes. And here, the one with the high OSI, that is ovarian sensitivity index, requiring higher dose, and the low OSI requiring the lower dose for the same number of oocytes. So does it matter? Does ovarian sensitivity matter? So we have this study here that was published in Fertility and Sterility quite some time ago. I would say don't focus on the title, because the title is a bit misleading. So basically what they looked at, if you look at all the columns, they look at the various oocyte number groups, that is 1 to 5, 6 to 10, 11 to 15, and so on. And then they looked at the gonadotrophin dose. And then they gave you all the live birth rates in each oocyte category based on the gonadotrophin dose. And as you can see, in all oocyte numbers, you can see that the higher the gonadotrophin dose required to attain the same oocyte numbers, the lower the live birth rate is. And if you have a higher OSI, then the live birth rate is lower. So if you need more gonadotrophins to get the same number of oocytes, then you have a lower live birth rate. So the title is misleading, as I said. It is not to do with the gonadotrophin dose. Gonadotrophin doses are safe. Of course, you don't give gonadotrophins more than they are needed, certainly not very high doses over 300, which makes no difference. But the gonadotrophin dose is not detrimental in terms of live birth rate or oocyte numbers. It is the background characteristics of that woman which make her require a higher amount of gonadotrophin to get the same number of oocytes, which is causing the lower live birth rate. And here I want to put up this document, and this is thanks to Alberto, who led on this KPI by the Italian society, fertility societies. And here they come up with a bit more comprehensive KPIs than the Maribor consensus, which asked us to refer to the Vienna consensus. And here they have the cycle cancellation rate, and they've given what should be the competence and benchmark values based on poor response and normal response. They've gone on a bit further, and they've added this, which is the late follicle to oocytes index. And congratulations, Alberto. This is the first society, I think, which has added this as a KPI. And they've got the benchmark values of greater than or the competence values of 50 or more, and the benchmark value of 80% or more for the late FOI. And then, of course, they have the proportion of mature oocytes and the rate of cycles with moderate to severe OHSS. So this KPI is a bit more clearer and a bit more finer in how they define the KPIs with regards to numerators and denominators as well, compared to the previous KPIs, which were a bit more vague in how to establish the number of follicles on the day of trigger and so on and so forth. There was no consensus on what the measurement should be. So we know the hyperresponse, low FOT, low FOI could be due to numerous reasons. The common reasons are advanced female age, and we saw in the previous lectures as well why it is that women with advanced reproductive age have a hyperresponse, low FOI, low FOT. And this is because the glycosylated forms of FSH vary within the age, and there's a reduction of androgens. The other contributing factors are treatment factors, and this is where we can make a difference. And this is iatrogenic, that is, we are not doing the right things, or we could have done better. And especially if we were to be more precision, more precision stimulation, not just individualized, but precise individualized stimulation, a bit further we could go, because every little helps. It can improve outcomes. And iatrogenic, not the right type of gonadotrophin, whether you need LH activity and what type of LH activity you give this particular patient. And we also heard from Christos very elegantly on the likelihood of genetic variants that could be of gonadotrophins and the receptors, which could have an impact. So the KPIs for ovarian stimulation and efficacy, so the ones that are existed and the ones that are published, the FOT, FOI, ovarian sensitivity index, measure the efficacy of ovarian stimulation a bit more better. But these KPIs, however, measure only at the end of stimulation. So you completed the stimulation cycle and you've come to the end, that is to the stage of mature follicles, or that you're ready to trigger, or the stage of oocyte retrieval. So you can't really remedy that current cycle because you've completed it. And therefore, KPIs to measure the performance of ovarian stimulation in real time are needed, which could allow protocol optimization within that index cycle. And what are these? And where and how does sensitivity matter? So when we are doing treatment cycles, where we do and what we do and how we do can matter at every stage. And this is very important. The antral follicle count, accurate assessment, ultrasound assessment. So the individual competencies matter here, and therefore we need to individualize stimulation based on this individualized precise stimulation, and also establish what should be considered as the denominator for FOAT and FOI. What is the size of the antral follicles, and when should the antral follicles, up to when can they be estimated? Then again, the next stage at which you can, where sensitivity matters, is stimulation. Again, precise protocols, precise stimulation, and that will have an impact on follicle recruitment, oocyte yield, and also the safety in terms of OHSS prevention. Final oocyte maturation trigger is also an important aspect. Again, it can affect impact on mature oocytes and also the prevention of OHSS. And of course, the oocyte retrieval, the technical skills, and also the timing of oocyte retrieval has an impact. So we've come up with this document, and thanks to all colleagues who collaborated on this, and this is to the benefit of patients. How can we do as better as clinicians to this group of patients, or indeed all our patients? How can we better evaluate ourselves? We have not been good at evaluating ourselves as much as they do in the lab, where they have very stringent KPIs and they do regular audits and remedy anything which is not up to the benchmark. So what can we do this? So this is a paper published recently in Fertility Sterility, and what we said that to be able to use KPIs in a dynamic way, that is in the same cycle, so that you can then make changes within the cycle itself rather than when it is too late and the stimulation is over, we've introduced such other KPIs. So to follow the physiological process of ovarian stimulation, recruitment, and oocyte maturation. So what are these? FOAT expanded to include early FOAT and modified FOAT, advanced, mature FOI, and modified and mature modified oocyte retrieval rate. ORR is oocyte retrieval rate. And here are these. So early FOAT is the number of follicles measuring 10 to 11 millimeters. So we've given what the measurement should be on day 5, 6 of ovarian stimulation divided by the antral follicle count. And the reason for this early FOAT is that early cycle day found to have high accuracy to predict ovarian response and allows in-cycle adjustments and refinements and changes to the stimulation where it can be rescued if anything needs to be remedied. Then you have the modified FOAT. The modified FOAT is the number of follicles measuring greater than 12 millimeters on the day of oocyte maturation triggering. So we've given a size divided by the antral follicle count. And the reason for that is that we should not be completely discounting the smaller follicles. The smaller follicles could also be competent and could also have yield oocytes that are that can translate into good outcomes. And then with regards to the other, which is the advanced FOI, which is mirroring what the Italians have proposed. And this is the ratio between the total number of oocytes retrieved and antral follicle count up to day 5 of stimulation. So we've mirrored what the Italian societies have put forth, and also the competence value and the benchmark values. and the advanced mature foy, which is the same as advanced foy, but instead of number of oocytes retrieved, to better evaluate, the numerator is number of mature oocytes retrieved, and AFC up to day 5 of stimulation. Then we have the modified oocyte retrieval rate, which is the number of oocytes retrieved as a proportion of follicles greater than 12, greater than 16 millimeters. So we have greater than or equal to 12 millimeters, as I said. We don't want to discount the smaller follicles completely. And then you have the modified mature ORR, which is looking at the mature oocytes retrieved. And this is the diagram which tells you across the stimulation at various stages where you can apply the various KPIs right from the start through the stimulation, starting early on and then up to the stage of oocyte retrieval. So at every stage that there is an intervention or when there is a prolonged intervention, we assess it at several stages. For all those who missed the previous slide, I can see a lot of cameras going up to take the picture. The paper is available free online, so you can read it, and you can refer to the figure as well. So sorry if I skipped the slide too quickly. To summarize, dear colleagues, so this is a very simple way or a simple KPIs for us to better improve patient outcomes, and what implementation of this full range of existing and newly proposed KPIs will only make treatments better and also will allow us to make precision treatments within the cycle to mitigate any incompetencies that we see within that stimulation cycle, not retrospectively once the treatment is over. It encourages reporting beyond just oocyte numbers, so it's not just the endpoint, even before that, and it might lead to an increase in the number of monitoring visits. It is 1 or 2 visits extra for a patient, but then if you ask a patient, what does the patient prefer? Does the patient is okay with coming for 1 or 2 extra visits to give them a better management, or have a suboptimal outcome or suboptimal response, which we can only pick up at the end, and we do not know which one will encounter that? The patients would definitely prefer the former. And of course, these KPIs need to be validated. So perhaps all of you in this audience can use these KPIs. And when we meet again, you can give us a feedback on how you're doing with these KPIs and how it is benefiting your patients or otherwise. Thank you very much.